and welcome to tonight's edition of Paramedic Current Practices. The paramedic profession and treatment practices have substantially evolved over the past few centuries. In today's world, pre-hospital treatment is a vital aspect of patient care, and in a lot of cases can be the difference between good and bad outcomes. These positive patient outcomes boil down to the paramedics themselves, and the knowledge and skills that they possess to perform a wide variety of procedures. One such procedure that is commonly used across a wide variety of conditions is intravenous fluid therapy using 0.9% saline. Tonight we're going to give you a brief introduction of fluid therapy and various conditions that it's used in. We will also present evidence on why 0.9% saline is an appropriate choice for intravenous fluid therapy in the pre-hospital setting. IV therapy is a process in which fluids, pain relief, or anti-nausea medication are delivered directly into a vein. Humans are made up of around 80% water, which means that fluid is the primary factor in homeostasis. Both fluid levels and electrolytes are meticulously controlled by the body in order to maintain this homeostasis. In a healthy human being, the body's intake of fluid predominantly comes from the food and drink that we consume on a day-to-day basis, and is lost mainly through sweating and urination. However, there are certain one-off incidents and occurrences which can potentially throw out this equilibrium on a colossal scale. And that is where pre-hospital IV fluid therapy comes into play. IV fluid therapy works through delivery of fluid directly into the bloodstream via a cannula. In theory, this fluid can then work to resuscitate a patient, replace lost fluids, or redistribute fluids around the body. With extensive research having been put into IV fluid therapy, it is now widely accepted that this therapy can be used for an array of conditions, such as sepsis, burns, shock, and neurotrauma. Now, over to Daniel to tell us more.
Thanks, Ethan. Sepsis is defined as a dysregulated systemic inflammatory and immune response to microbial invasion that produces organ injury. Septic shock is a progression of sepsis with hyperlactatemia and concurrent hypotension. This happens due to systemic vasodilation and increased membrane permeability, leading to an intravascular fluid deficit. As described by Winters 2017 and Semler 2016, intravenous, or IV, fluid therapy has been shown to be a vital component in early sepsis management, as it aims to augment cardiac output and improve tissue perfusion and oxygenation by increasing intravascular fluid. A landmark 2001 study by Rivers shows significantly improved outcomes in patients who received early goal-directed fluid therapy, with a 500 ml bolus of crystalloids given every 30 minutes. This study highlighted the importance of fluid therapy in the treatment of septic shock. According to Melbourne 2018, studies spanning over 70,000 patients have shown that fluid administration significantly reduces mortality, which has made it a protocol treatment for sepsis. Maric et al. 2017 have conducted an analysis of the US national database and have shown that fluid administration of between 1 to 5 litres reduced mortality by 0.7% for each litre. Surviving Sepsis Campaign 2013 has international guidelines that include fluid therapy for hemodynamic support, but stating that it should only be continued if there's any improvement, heart rate, pulse pressure, etc., which is why 0.9% saline is considered a drug therapy with drug-response relationship and should be individualized for each patient. Other clinical trials have demonstrated that sepsis is not primarily a volume-depleted state, and that most septic patients are poorly responsive to fluids, but it still acknowledges the importance of the use of fluid through a hemodynamically guided conservative approach. Now over to Jaden with burns.
Burns, as evidenced by the existence of specialized burns units, are complex injuries, which can cause multiple forms of fluid loss, resulting in what could be considered a mix of multiple types of shock. When tissues are damaged from injuries like burns, localized fluid leakage and edema occurs, due to responding inflammatory mediators increasing the capillary permeability, a process investigated by Widgerow et al. In the review on exudate in burns. While exudate was found to be an important part of inflammatory response with multiple uses, it displaces fluid volume from the blood vessels, and in studies which aim to quantify fluid loss over time, such as from Namdar et al., these effects were found to persist as patients continually lost fluid for many days after the initial infliction. These findings on injuries are clinically important, particularly for burns, as in a 2016 review of burn injury progression, Salevian et al. Found that burns and their prolonged inflammatory responses lead to additional detrimental circulatory effects, which are associated with an increased production of reactive oxygen species. Now, a comprehensive review on reactive oxygen species, as conducted by Mittal, Siddiqui, Tran, Reddy, and Malik, found that these toxic cell metabolites cause systemic vasodilation of the blood vessels, compounding with additional fluid loss from further increasing capillary permeability. Now, because burns patients suffer from decreased volume and vasodilatory effects, blood pressure declines and potentially leads to impaired perfusion. As is outlined on reviews on fluid resuscitation, like that from Louis et al., every fluid has advantages and disadvantages, but the ideal fluid choice will be able to restore fluid volume and maintain circulation with no adverse effects. Now, we'll have more information on these choices later.
Fluid therapy is a significant intervention for head injuries in the pre-hospital environment. It is the essential tool used by paramedics when treating severe trauma events. However, recent literature has discussed that excessive fluid therapy can contribute to further neurological deficits if not properly managed. According to the article by Chang, 2014, neurotrauma not only results from primary brain injury, but also from secondary brain injury due to hypotension or hypoxemia. Therefore, the individual life is heavily dependent on the methods of pre-hospital care. If the patient condition is severe, cerebral edema and the increase of intracranial pressure will develop. As a result, cerebral blood flow is compromised. If the patient is left in this condition, a number of detrimental adverse events will occur, such as herniation of the brain substance, mobility, and cerebral ischemia. According to the article by Paramedic 2016, adequate fluid resuscitation to restore the patient's hemodynamics is essential to maintain the cerebral blood flow. However, excess fluid therapy will contribute to further cranial edema and increased ICP, which will also cause morbidity. Therefore, maintaining the mean arterial pressure of greater or equal to 85 mm of mercury is commonly used in practice and guidelines, as outlined in the article by Chang. Therefore, an article by Jeff Colt, 2010, maintaining fluid is the safest and most effective method of pre-hospital fluid therapy for neurotrauma, if given in a steady, controlled, and low quantity of IV isotonic crystallized solution. Saline therapy is an adequate and extremely beneficial form of treatment that will effectively prevent detrimental adverse events from developing until the patient arrives at the hospital where further treatment is available.
Crystalloid fluid therapy is a common treatment for patients suffering hypovolemic shock, particularly caused by trauma. Hypovolemic shock is a term used to describe inadequate organ perfusion caused by reduced circulating volume. Replacing that lost volume helps restore blood pressure and increases cardiac output, improving the circulation of oxygen-carrying hemoglobin in the remainder of the blood and therefore increasing tissue perfusion. Fluid administration in trauma patients is a widely accepted practice. A 2017 study showed the majority of US EMS protocols suggest fluid administration for hypovolemic patients. Because of this common practice, extensive research has been done regarding risks of fluid resuscitation and what level of administration promotes best patient outcomes. A study conducted by Bickel in 1994 marks one of the breakthrough articles regarding fluid therapy. The Bickel study discussed the impact of aggressive versus conservative fluid therapy and concluded that higher fluid volume is linked to increased complications. This conclusion was supported by Ponshab's contemporary study that found high volume administration of crystalloid may negatively influence clinical parameters such as higher blood pressure, lower body temperature, and impaired coagulation parameters, which could potentially increase bleeding after trauma. To minimize this risk, it is suggested that reducing the administration of unnecessary and excessive fluid volume is crucial. This low-volume approach for reperfusion, as researched by Hushman and Morrison, is called permissive hypotension, as the purposeful allowance of hypotension is considered acceptable. Dunz's 2013 study discusses prioritizing reperfusion goals in severe trauma patients. These goals focus on initially prioritizing heart and brain perfusion, then continue to peripheral perfusion, and finally complete individual organ perfusion. Dunz determined that a mean arterial pressure of 50 millimeters of mercury or above is appropriate to maintain heart and brain perfusion and should be the initial target for these patients. Morrison conducted a similar study and determined that a MAP of 65 millimeters of mercury or above, which is about 80% of the normal MAP of a healthy patient, is considered normal target for treatment of hypotensive trauma patients. Therefore, it was concluded that a MAP of 50 millimeters of mercury or above follows the permissive hypotension approach. These principles can be summarized by a study conducted by Chang and Holcomb, which describes the term damage control resuscitation, or DCR. DCR applies the principles of reduced volume administration, permissive hypotension, and correcting coagulopathy. The study also concluded that effective resuscitation of hypotensive trauma patients has as much impact on the patient outcomes as the surgical management of the presenting injuries, demonstrating the importance of appropriate fluid therapy.
The 2004 SAFE study found that normal saline and albumin have similar outcomes in mortality and organ failure at 28 days. When this is considered against the NICE guidelines finding that albumin would need to avoid an extra 65 to 72 major complications per 1,000 patients to make it cost neutral with normal saline, it becomes clear that normal saline has a significant advantage in cost effectiveness. In a systematic review of randomized controlled trials, Perel also points out the cost effectiveness of normal saline as compared to colloids, which were found to have no improvements in outcome compared to saline and yet had significantly higher costs. All cost comparisons found saline to be the most cost-effective option based on acquisition costs alone, with no consideration of the additional storage or administration costs associated with other fluid options. In addition to its cost-effectiveness, normal saline is useful in emergency settings due to its low risk of allergic reaction, which has only been reported twice in the literature. This is particularly beneficial in time-critical situations and when patient information is difficult or not possible to obtain. The lack of a requirement for cross-matching is also of benefit in these situations. Normal saline is also easy to store with no requirement for refrigeration and has a good shelf life. It can also be used for multiple purposes, making it ideal for on-road use, particularly in rural and remote areas. It may not be blood, but for intravenous fluid therapy in the pre-hospital setting, saline, when used in the right dose, for the right patient type, and at the right time, with the right monitoring and the right reevaluation, is the right drug. Back to you, Ethan.
Fluid therapy, like any other medical practice, is not without its potential dangers. However, when combined with quality clinical judgment and decision-making, fluid therapy could possibly be the difference between life and death for a critically ill patient. As stated earlier, in the correct situations, fluid therapy can greatly increase the chances of a positive patient outcome in sepsis, shock, neurotrauma, and patients who have suffered burns. Furthermore, the cost of IV fluid therapy in comparison to that of using blood products and its superior practicality makes it an effective treatment that can be used by paramedics in the pre-hospital setting.